Hey everyone, this is your Nandini ma'am. Today we'll be continuing our chapter number 2 of Bones, Human Anatomy from B.D. Chaurasia, and we'll continue from carpal bones. So let's get started. The carpus is made up of 8 carpal bones which are arranged in 2 rows, figure 2.28. The proximal row contains from lateral to medial side the scaphoid, the lunate, triquetral, the pisiform. The distal row contains in the same order the trapezium, the trapezoid, the capitate, the hamate. Identification. The scaphoid is boat-shaped and has a tubercle on its lateral side. Number 2. The lunate is half-moon shaped or crescentic. Number 3. Triquetral is pyramidal in shape and has an isolated oval facet on the distal part of the palmar surface. Number 4. The pisiform is P-shaped and has only one oval facet on the proximal part of its dorsal surface. Number 5. The trapezium is quadrangular in shape and has a crest and a groove anteriorly. It has a sella, which is concavo-convex articular surface distally. Number 6. The trapezoid resembles the shoe of a baby. Number 7. The capitate is the largest carpal bone with a rounded head. Number 8. The hamate is wedge-shaped with a hook near its base. Side determination. Journal points. Number 1. The proximal row is convex proximally and concave distally. Number 2. The distal row is convex proximally and flat distally. Number 3. Each bone has 6 surfaces. The palmar and dorsal surfaces are non-articular except for the triquetral and pisiform. The lateral surfaces of the 2 lateral bones are non-articular. The medial surfaces of the 3 medial bones are non-articular. Number 4. The dorsal non-articular surface is always larger than the palmar non-articular surface except for the lunate in which the palmar surface is larger than the dorsal. The journal points help in identifying the proximal, distal, palmar, and dorsal surfaces in most of the bones. The site can be finally determined with the help of the specific points. Specific points. Number 1. The scaphoid. The tubercle is directed laterally, forward, and downwards. Number 2. The lunate. A small semi-lunar articular surface for the scaphoid is on the lateral side. A quadrilateral articular surface for the triquetral is on the medial side. Number 3. The triquetral. The oval facet for the pisiform lies on the distal part of the palmar surface. The medial and dorsal surfaces are continuous and non-articular. The pisiform. The oval facet for the triquetral lies on the proximal part of the dorsal surface. The lateral surface is grooved by the ulnar nerve. Number 5. The trapezium. The palmar surface has a vertical groove for the tendon of the flexor carpi radialis. The groove is limited laterally by the crest of the trapezium. The distal surface bears a sellar concavo-convex articular surface for the base of the first metacarpal bone. Number 6. The trapezoid. The distal articular surface is bigger than the proximal. The palmar non-articular surface is prolonged laterally. Number 7. The capitate. The dorsomedial angle is the distal-most projection from the body of the capitate. It bears a small facet for the fourth metacarpal bone. Number 8. The hamate. The hook projects from the distal part of the palmar surface and is directed laterally. Attachments. There are 4 bony pillars at the 4 corners of the carpus. All attachments are to these 4 pillars. Figure 2.28. Number 1. The tubercle of the scaphoid. The flexor retinaculum, a few fibers of the abductor pollicis brevis. Number 2. The pisiform gives insertion to the flexor carpi ulnaris. Pisiform is a sesamoid bone in tendon of FCU. Flexor retinaculum and its superficial slip. See figure 9.15. Abductor digiti minimi, figure 2.32b. Extensor retinaculum, see figure 9.52. Number 3. The trapezium. The crest gives origin to the abductor pollicis brevis flexor pollicis brevis, and opponens pollicis. These constitute muscles of the thenar eminence, figure 2.32b. The edges of the groove give attachment to the two layers of the flexor retinaculum. The lateral surface gives attachment to the lateral ligament of the wrist joint. The groove lodges the tendon of the flexor carpi radialis. Number 4. The hamate. The tip of the hook gives attachment to the flexor retinaculum. See figure 9.15. The medial side of the hook gives attachment to the flexor digiti minimi and opponens digiti minimi. Articulations. The scaphoid. Radius, lunate, trapezium, trapezoid, capitate. Figures 2.32b and c. The lunate. Radius, scaphoid, capitate, hamate, and triquetral. The triquetral. Pisiform, lunate, hamate, and articular disc of the inferior radio-ulnar joint. The pisiform articulates only with the triquetral. The trapezium. Scaphoid, first and second metacarpals, and trapezoid. The trapezoid. Scaphoid, trapezium, second metacarpal, and capitate. The capitate. Scaphoid, lunate, hamate, second, third, and fourth metacarpals, and trapezoid. The hamate. Lunate, triquetral, capitate, and fourth and fifth metacarpals. Ossifications. The year of appearance of center of ossification in the carpal bones is shown in figure 2.29. Clinical anatomy. Fracture of the scaphoid is quite common. The bone fractures through the waist at right angles to its long axis. The fracture is caused by a fall on the outstretched hand or on the tips of the fingers. This causes tenderness and swelling in the anatomical snuff box and pain on longitudinal percussion of the thumb and index finger. The residual disability is more marked in the mid-carpal joint than in the wrist joint. The importance of the fracture lies in its liability to non-union and avascular necrosis of the body of the bone with pain in anatomical snuff box. Normally, the scaphoid has two nutrient arteries, one entering the palmar surface of the tubercle and the other the dorsal surface of the body. Occasionally, both vessels enter through the tubercle or through the distal half of the bone. In such cases, fracture may deprive the proximal half of the bone of its blood supply, leading to avascular necrosis, figure 2.30. It may be treated on the lines of osteoarthritis. Dislocation of the lunate may be produced by a fall on the acutely dorsiflexed hand with the elbow joint flexed. This displaces the lunate anteriorly, also leading to carpal tunnel syndrome-like features, figures 2.31a to c. Metacarpal bones. Number 1. The metacarpal bones are 5 miniature long bones which are numbered from the lateral to the medial side, figure 2.28. Number 2. Each bone has a head placed distally, a shaft, and a base at the proximal end. The head is round. It has an articular surface which extends more anterior-posteriorly than laterally. It extends more on the palmar surface than on the dorsal surface. The heads of the metacarpal bones form the knuckles during flexion. The shaft is concave on the palmar surface. Its dorsal surface bears a triangular area in its distal part. The base is irregularly expanded, figure 2.32a. Third, a metacarpal bone can be distinguished from a metatarsal bone because of the differences given in table 2.3. Characteristics of individual metacarpal bones. First, it is the shortest and stoutest of all metacarpal bones, figure 2.32b. The base is occupied by a concavo-convex articular surface for the trapezium. The dorsal surface of the shaft is uniformly convex, figure 2.32c. The head is less convex and broader from side to side than the heads of other metacarpals. The ulnar and radial corners of the palmar surface show impressions for sesamoid bones. The first metacarpal bone, lying on a more anterior plane, is rotated medially through 90 degrees relative to the other metacarpals. As a result of this rotation, the movements of the thumb take place at right angles to those of other digits. It does not articulate with any other metacarpal bone. Second, the base is grooved from before backwards. The medial edge of the groove is larger. Figure 2.32a. Third, the base has a styloid process projecting up from the dorsolateral corner. Figure 2.32a. Fourth, the base has two small oval facets on its lateral side for the third metacarpal, and on its medial side, it has a single elongated facet for the fifth metacarpal. Figure 2.32a. Fifth, the base has an elongated articular strip on its lateral side for the fourth metacarpal. The medial side of the base is non-articular and bears a tubercle. Side determination of metacarpals. The proximal, distal, palmar, and dorsal aspects of each metacarpal bone can be made out from what has been stated above. The lateral and medial sides can be confirmed by the following criteria. First, the anterior lateral surface is larger than the anterior medial, figure 2.32b. Second, the medial edge of the groove on the base is deeper than the lateral edge. The medial side of the base bears an articular strip which is constricted in the middle. Third, the styloid process is dorsolateral. The lateral side of the base bears an articular strip which is constricted in the middle. The medial side of the base has two small oval facets for the fourth metacarpal. Fourth, the lateral side of the base has two small oval facets for the third metacarpal. The medial side of the base has an elongated articular strip for the fifth metacarpal. The lateral side of the base has an elongated articular strip for the fourth metacarpal. This is for the fifth metacarpal. The medial side of the base is non-articular and has a tubercle. Differences between metacarpals and metatarsals. The head and shaft are prismoid, whereas the head and shaft are flattened from side to side. The shaft is of uniform thickness. The shaft tapers distally. The dorsal surface of the shaft has an elongated, flat, triangular area. The dorsal surface of the shaft is uniformly convex. The base is irregular. The base appears to be cut sharply and obliquely. Main attachments of metacarpals. The main attachments from shaft of metacarpals are of palmar and dorsal interosseous muscles. Palmar interosseous arise from one bone each except the third metacarpal. Figure 2.32b. Dorsal interosseous arise from adjacent sides of two metacarpals. Figure 2.32c. The other attachments are listed below. First, the opponent's pollicis is inserted on the radial border and anterior lateral surface of the shaft, figure 2.32b. The abductor pollicis longus is inserted on the lateral side of the base. The first palmar interosseous muscle arises from the ulnar side of the base. Second, the flexor carpi radialis is inserted on a tubercle on the palmar surface of the base, figure 2.32b. The extensor carpi radialis longus is inserted on the dorsal surface of the base, figure 2.32c. The oblique head of the abductor pollicis arises from the palmar surface of the base. Third, a slip from the flexor carpi radialis is inserted on the palmar surface of the base. The extensor carpi radialis brevis is inserted on the dorsal surface of the base immediately beyond the styloid process. The oblique head of the adductor pollicis arises from the palmar surface of the base, figure 2.32b. The transverse head of the adductor pollicis arises from the distal 2/3 of the palmar surface of the shaft, figure 2.32b. Fourth, only the interosseae arise from it, figures 2.32b and c. Fifth, the extensor carpi ulnaris is inserted on the tubercle at the base. The opponent's digiti minimi is inserted on the medial surface of the shaft, figure 2.32b. Articulations at the bases. First, with the trapezium forms saddle-shaped joint. Second, with the trapezium, the trapezoid, the capitate, and the third metacarpal, figure 2.32b and c. Third, with the capitate and the second and fourth metacarpals. Fourth, with the capitate, the hamate, and the third and fifth metacarpals. Fifth, with the hamate and the fourth metacarpal. Ossification. The shafts ossify from one primary center each, which appears during the ninth week of development. A secondary center for the head appears in the second to fifth metacarpals and for the base in the first metacarpal. It appears during the second to third year and fuses with the shaft at about 16 to 18 years, figure 2.29. Clinical anatomy. Fracture of the base of the first metacarpal is called Bennett's fracture. It involves the anterior part of the base and is caused by a force along its long axis. The thumb is forced into a semi-flexed position and cannot be opposed. The fist cannot be clenched. Figure 2.33. The other metacarpals may also be fractured by direct or indirect violence. Direct violence usually displaces the fractured segment forwards. Indirect violence displaces them backwards. Figure 2.34. Tubercular or syphilitic disease of the metacarpals or phalanges in a child is located in the middle of the diaphysis rather than in the metaphysis because the nutrient artery breaks up into a plexus immediately upon reaching the medullary cavity. In adults, however, the chances of infection are minimized because the nutrient artery is replaced as the major source of supply by periosteal vessels. When the thumb possesses three phalanges, the first metacarpal has two epiphyses, one at each end. Occasionally, the first metacarpal bifurcates distally. Then, the medial branch has no distal epiphysis and has only two phalanges. The lateral branch has a distal epiphysis and three phalanges. Figure 2.35. The total digits are 6 in such case, polydactyly. Phalanges. There are 14 phalanges in each hand, 3 for each finger and 2 for the thumb. Each phalanx has a base, a shaft, and a head. Base. In the proximal phalanx, the base is marked by a concave oval facet for articulation with the head of the metacarpal bone. In the middle phalanx or a distal phalanx, it is marked by two small concave facets separated by a smooth ridge. Shaft. The shaft tapers towards the head. The dorsal surface is convex from side to side. The palmar surface is flattened from side to side, but is gently concave in its long axis. Head. In the proximal and middle phalanges, the head has a pulley-shaped articular surface. In the distal phalanges, the head is non-articular and is marked anteriorly by a rough horseshoe-shaped tuberosity which supports the sensitive pulp of the finger or tip. Attachments. Number 1. Base of the distal phalanx. The flexor digitorum profundus is inserted on the palmar surface, figure 2.32b. Two side slips of digital expansion fuse to be inserted on the dorsal surface. These also extend the insertion of lumbrical and interossei muscles, figure 2.32c. Number 2. The middle phalanx. The two slips of flexor digitorum superficialis are inserted on each side of the shaft, figure 2.32b. The fibrous flexor sheath is also attached to the side of the shaft. A major part of the extensor digitorum is inserted on the dorsal surface of the base through dorsal digital expansion, figure 2.32c. The proximal phalanx. The fibrous flexor sheath is attached to the sides of the shaft. On each side of the base, parts of the lumbricals and interossei are inserted. Number 4. In the thumb, the base of the proximal phalanx provides attachments to the following structures. Figure 2.32b. Third, the proximal phalanx. The fibrous flexor sheath is attached to the sides of the shaft. On each side of the base, parts of the lumbricals and interossei are inserted. Fourth, in the thumb, the base of the proximal phalanx provides attachments to the following structures. Figure 2.32b. The abductor pollicis brevis and flexor pollicis brevis are inserted on the lateral side. The adductor pollicis and the first palmar interosseous are inserted on the medial side. The extensor pollicis brevis is inserted on the dorsal surface. Figure 2.32c. Fifth, in the little finger, the medial side of the base of the proximal phalanx provides insertion to the abductor digiti minimi and the flexor digiti minimi. Figure 2.32b. Ossification. The shaft of each phalanx ossifies from a primary center which appears during the 8th week of development in the distal phalanx, 10th week in the proximal phalanx, and 12th week in the middle phalanx. The secondary center appears for the base during 2 to 4 years and fuses with the shaft during 15 to 18 years, figure 2.29. Clinical anatomy. Fracture of distal phalanx of middle finger is commonest. It is treated by splinting the injured phalanx to the adjacent normal finger. This is called buddy splint. Figure 2.36 shows buddy splint of the fingers. Sesamoid bones. Sesamoid bones are small, rounded masses of bones located in some tendons at points where they are subjected to great pressure. They are variable in their occurrence. These are as follows. 1. The pisiform is often regarded as a sesamoid bone lying within the tendon of the flexor carpi ulnaris. Two sesamoid bones are always found on the palmar surface of the head of the first metacarpal bone. Number 3. One sesamoid bone is found in the capsule of the interphalangeal joint of the thumb in 75% of subjects. One sesamoid bone is found on the ulnar side of the capsule of the metacarpophalangeal joint of the little finger in about 75% of subjects. Number 5. Less frequently, there is a sesamoid bone on the lateral side of the metacarpophalangeal joint of the index finger. Number 6. Sometimes sesamoid bone may be found at other metacarpophalangeal joints. Facts to remember. Axillary, radial, and ulnar nerves are intimately related to humerus and are liable to be injured. Radial pulse is felt close to the lower end of shaft of radius. Pisiform bone is a sesamoid bone in the tendon of flexor carpi ulnaris muscle. First metacarpal is the shortest and strongest of metacarpals. It is situated at an angle to the other bones, thus permitting opposition of the thumb. Third metacarpal is the longest and the axis of abduction and adduction passes through its center. Mnemonics. Carpal bones. She looks too pretty. Try to catch her. Lateral to medial. Proximal row. Scaphoid. Lunate. Triquetral. Pisiform. Distal row. Trapezium. Trapezoid. Capitate. Hamlet. Elbow. Which side has common flexor origin? FM. Flexor medial. So common flexor origin is on the medial side. Bicipital groove of humerus. Lady between two majors. Lateral lip. Pectoralis major. Medial lip. Teres major. Floor. Latissimus dorsi. Arm fracture. Nerves affected by humerus fracture. From superior to inferior. Axillary. Neck of humerus. Radial. Midshaft. Ulnar. Behind medial epicondyle. Clinico-anatomical problem. A 50-year-old man fell off his bicycle. He heard a cracking noise and felt severe pain in his right shoulder region. He noted that the lateral part of the shoulder drooped and medial end of clavicle was elevated. Which is the common site of fracture of clavicle and why? Why did his shoulder droop down? The clavicle gets fractured at the junction of medial 2/3 and lateral 1/3. This is the weak point as it lies at the junction of two opposing curvatures. The shoulder drooped down because of the weight of the unsupported shoulder. So this was your chapter number 2. Happy reading and happy learning.